Good morning, and thank you for this kind invitation in this important meeting. So, my presentation will deal in fetal hemodynamics in intrauterine growth-restricted fetuses. So, let's start with the definition of intrauterine growth restriction. First of all, I want to underline the difference between IUGR and SGA, small for gestational age. This is a term used by neonatologists that comprise an heterogeneous group of fetuses that have failed to achieve their growth potential, the real IUGR, and the fetuses that are constitutionally small. When we talk about IUGR, intrauterine growth restriction, this definition identifies fetuses that do not achieve their growth potential. And particularly, their diagnosis is based on the sonographic evidence of abdominal circumference or estimated fetal weight values below the 10th centile of the biometric reference curve in gestations correctly dated. As a methodological approach, we have to perform a correct evaluation of the gestational age. Particularly, we have to refer to the first trimester sonography in order to be aware that the gestation is correctly dated. We have to consider the ultrasound biometric trend rather than the absolute value. Why it is important to make the diagnosis of IUGR fetus before birth? You can see from these slides we have many reasons, but particularly we have to identify these fetuses because they are at hypoxic risk and can have some kind of sequelae that I'm going to show you. But also because we have to be able to make the etiological diagnosis. This patient may develop pregnancy-induced hypertension. These fetuses, after the delivery, may have some perinatal complications, particularly multi-systems compromise, particularly the brain injuries, intrauterine mortality, but also because in some severe cases of IUGR fetuses, we have to plan time, mode, and site of delivery. And we have to plan a management with multidisciplinary approach. And particularly important is the collaboration with neonatologists. But also because these fetuses may develop chronic disease in adult life like type 2 diabetes and hypertension. If we look to the chronic fetal oxygen deficiency, the main causes of IUGR, as you can see here, are the placental insufficiency and umbilical cord anomalies. If we look to the pathophysiology of IUGR, we can see that placental pathologies and umbilical cord pathologies may produce an impaired gas and metabolic exchange between the mother and the fetus. And the fetus try to face this situation, changing the hemodynamics, reducing the growth rate, and changing the biophysical profile. All these strategies are used by the fetus in order to avoid the fetal organ system injuries and finally the fetal death. We have to be able to identify the hemodynamic modification or alteration, the reduction of the fetal growth, and the alteration in biophysical profile in order to avoid the injuries. We know that the fetal hemodynamics is widely used for the evaluation of fetal condition during different maternal and fetal pathophysiological processes that are commonly related to oxygen deficiency and intrauterine growth restriction. The evaluation of fetal oxygen deficiency is one of the major challenges of fetal medicine, and its fundamental aim is the prevention of fetal oxygen deficiency related problems, particularly fetal compromise, as I told you, multi-systems injuries and particularly fetal brain injuries, and finally the fetal death. What is the recommended approach in presence of suspected IUGR? We have to verify the dating of gestation and evaluate, as I told you, the trend of fetal growth rather than the absolute value. We have to evaluate the whole clinical picture, considering the presence of risk factors and the maternal clinical condition. We have to preserve the mother and then the fetus. We have to evaluate the immunological status of the patient for infection at risk of maternal fetal transmission and for autoantibody syndromes. After that, we have to perform an accurate evaluation of fetal anomaly, fetal anatomy in order to exclude fetal anomalies, and particularly we have to keep attention to exclude cardiac abnormalities. We have to evaluate then the amniotic fluid, the amount of amniotic fluid, and after that we have to evaluate the uteroplacental and fetal hemodynamics. In case of suspected IUGR, we may have some possible scenarios. You can see here we have two scenarios that are not real IUGR as classically defined, because the first one is related to baby that are constitutionally small, and the other one, the so-called anomalous IUGR, is related to pathology, to fetal pathology, to fetal abnormalities. The real IUGR are the scenarios that you can see in this slide. In relation with the pathophysiology and in relation to the onset of these kind of scenarios, we have three possible scenarios: the early onset IUGR, the late onset IUGR, and the scenarios that I called some years ago atypical IUGR, that is due to umbilical cord anomalies. The two first scenarios, the early onset and late onset, are mainly related to placental insufficiency. The early onset is the first scenario that I'm going to show you, and the main aspect of this scenario is, as you can see, the gestational age less than 32 weeks of gestation, maternal pregnancy-induced hypertension very frequently, small fetus, normal morphology, oligohydramnios, increased impedance to flow values in the uteroplacental district, increased impedance to flow value in the umbilical arteries, and particularly important is the typical cascade of hemodynamic events that I'm going to show you. It is very important to identify this kind of fetuses because they are fetuses at hypoxic risk. Talking about the typical cascade of hemodynamic event, I want to divide this cascade in some stages. The first stage that I want to show you is the stage of uteroplacental hemodynamic alteration that I described many years ago. As I told you, the placental insufficiency produces an appropriate trophoblastic invasion and placental hemodynamic alteration with reduction of placental perfusion that produce a persistence or increase of high impedance to flow with notch, the protodiastolic notch, in the waveform profile of the uterine artery. And from the fetal side, we can see a persistence or increase or high impedance to flow in the umbilical arteries. Here is the scheme of this stage that are characterized by small fetuses and the hemodynamics that is characterized by an alteration in uterine artery hemodynamics. That is one of the most important aspects of this very early stage. The next stage is the early stage of dynamic redistribution, and as you can see here, looking at the pathophysiology, the alteration in the placenta, structural and functional alteration in the placenta, produce an hypercapnia and hypoxemia in the fetus that produce a peripheral arterial vasoconstriction and a cerebral vasodilation with increased cerebral blood flow in this organ, because this organ is very important for the intrauterine fetal life. And so the fetus try to shift the blood, the output, the cardiac output, to the organs that are more important for the fetal life, so the brain, the heart, and adrenals. So if we look to the hemodynamics in this stage, we can see in this stage a vasodilation in cerebral vessel. You can see the hemicircle of Willis, and it is possible in this stage to identify a reduction in impedance to flow. So the fetus is pushing more blood because it's less oxygenated in order to supply the fetal brain. If we look to the intracardiac hemodynamics, we can see that an increased aortic valve time to peak velocity. Why? You can see here, when we have an increased time to peak velocity, the meaning is that the district supplied by this hemodynamic segment is site of decreased resistance. And you can see here why, because the blood coming from the left ventricle to the aortic valve is going into the ascending aorta and to the aortic arch, supplying the head and the brain, which is site of vasodilation. The opposite phenomenon is possible to find in the hemodynamics of the pulmonary valve. In fact, in this valve, we can see a reduction in the time to peak velocity. And the meaning is an increased resistance. You can see here the blood coming from the right ventricle is going to the main pulmonary artery, and through the ductus arteriosus supply the body and placenta, which is side the body of vasoconstriction, in order, as I told you, to shift more blood to the organs that are more important for the fetal life, particularly the brain, and the placenta, which is site of some structural, functional, and functional anomalies. So, in the pulmonary valve, we find a reduction in the time to peak velocity. And here is the scan. I underline some hemodynamic aspects that are more important for the clinical practice, and particularly we can see the reduction in impedance to flow in the cerebral district, particularly is used the main cerebral artery in the proximal portion. We can find an increased impedance to flow in the arterial district, and particularly also in the umbilical artery, an alteration in the pulmonary valve and the aortic valve time to peak velocity, and as usual, because it's an essential aspect of the IUGR fetuses, an altered perfusion in the uterine arteries. The next stage is the stage that I call it advanced stage of hemodynamic redistribution. What is new in this advanced stage? The news is that we can find this kind of phenomenon in the arterial district of the fetus and in the umbilical artery. This condition that is characterized by the absent diastolic flow. Here you can see the normal waveform profile in the arterial district and in the umbilical artery in normal and healthy fetuses. If we look to the brain, you can see that we have obviously a very massive vasodilation in the brain, with a reduction in the impedance to flow value with high velocity during diastole. But if we look to the umbilical artery, we can see the absent flow, and again altered placental perfusion that must be always present. Here is the scan of this phase, of this stage, and the news is the absent diastolic flow in the arterial district and in the umbilical artery. Next stage is the stage that I called stage of hemodynamic decompensation, which is characterized by an incipient heart failure. So the news in this stage is the reverse flow during diastole. It's a classical sign of fetal compromise or fetal incipient heart failure. You can see altered perfusion in the placenta, reverse flow during diastole in the arterial district and in the umbilical cord, umbilical arteries. If we study in this decompensation stage the cerebral hemodynamics, we see a reduction in the perfusion, which is characterized by a reduction in the forward flow and particularly a reduction in the diastolic flow. You can see very clearly here, we have a reduction in the forward flow and a reduction particularly in the diastolic flow, with reverse flow in the umbilical artery and in the other arterial district of the fetus, and always present an altered placental perfusion. If we look into the heart, what is the hemodynamics in the heart, and if we look into the aortic valve, we can see that there is a reduction of peak velocity. Now we are talking not to time to peak velocity, but to peak velocity. And what is the meaning of decreased peak velocity in the aortic, in the pulmonary valve, is decreased cardiac contractility. And this is the situation that characterizes these IUGR fetuses in the compensating phase. The same happened in the pulmonary valve, obviously, and the reason is the same. So the ventricular myocardium is not performing very well, and the velocity, the blood velocity through the valves, the aortic and the pulmonary valve, is reduced. If we look to the atrioventricular inflow, we can see that there is a wall reduction in the forward flow, but the reduction is particularly evident by the A phase, that is the active phase produced by the contraction of the atrial myocardium. And the reason is the same, because this myocardium, the atrial myocardium, is facing the same condition that the ventricular myocardium, with less availability of oxygen and substrate, and the performance of this part of myocardium is reduced. And now let's move to the venous district of the fetus, starting from the ductus venosus. You can see here, in normal healthy fetuses, the waveform profile in this vessel, and you can see what's happened in this condition of the compensating phase. You can see a reduction in the forward flow and an appearance of reverse flow during the atrial contraction. You can see here, very evident reduction in the forward flow and appearance of reverse flow during the atrial contraction. Why? Because the hemodynamic event of the right side of the heart produced the alteration in the ductus venosus that is directly connected to the right atrium. If we look to the right venous return, we can find the same condition. You can see here that in normal condition there is very small reverse flow during the atrial contraction. But look here what's happened in this situation. Reduction of forward flow and higher velocity in correspondence with the atrial contraction. And here you can see that the hemodynamic event that characterize the right side of the heart, which is side of incipient heart failure, produce some abnormalities in the waveform profile in the venous district and particularly in the inferior vena cava that is directly connected with the right atrium. Finally, I want to show you what's happened in the umbilical vein. At the beginning, we can see that there is preserved flow in the umbilical vein, but you can see here some pulsation related with the cardiac cycle that are different with this kind of pulsation, that are not related with the cardiac cycle and is due to fetal breathing. But if we have a kind of progression to an incipient heart failure, you can see here we have a higher pulsation in the umbilical vein and very close to the fetal death. We can see that there is not only pulsation but a reduction in the forward flow in the umbilical vein. So the meaning is there is no blood circulating in the umbilical vein, and the meaning is that the fetus is going to die. So here you can see the scheme of this stage that possibly we should avoid in order to preserve the fetal compromise and in this stage also the fetal death. So I showed the typical cascade of hemodynamic event in early onset IUGR, but there is another scenario that is very important, that is characterized by some particular aspect, and the main aspect are underlined by the arrow, particularly the gestational age is more than 32 weeks. We have a less frequent involvement on the maternal side, and particularly, as you can see here, the pregnancy-induced hypertension is less present, less frequent, and generally are a late phenomenon. We have the absence of the typical cascade that I showed you before, and the hemodynamics is characterized mainly by the brain sparing with the altered cerebral placental ratio. It is very important, again, to make the diagnosis of these fetuses, because also these fetuses with apparent less evident hemodynamic change are at hypoxic risk and may have sequelae. Here you can see the different hemodynamics that characterize these two types of IUGR, the early on the left and the late onset IUGR on the right. You can see, for example, that the amniotic fluid that is dramatically reduced and very rapid decreased in the early onset is not so evident in the late onset and may be between the normal range. We can see that the ductus venosus may be normal, uterine artery is normal, telling us that the placental perfusion is not so altered as in the early onset. But you can see here the umbilical artery and the mid-cerebral arteries, even if are not so altered, looking at the reference value, but they are out of the normal range. So the ratio between the umbilical artery and the middle cerebral artery is always, even at the beginning of this clinical condition, altered. Look here, alteration that we can find in the early onset is always present also in the late onset, but the problem is that they are very late and generally they are very close to the fetal death and almost to the fetal sequelae. These apparently less evident hemodynamics very rapidly can be characterized by dramatic alteration in the fetal hemodynamics that can produce some sequelae and the fetal death. Here you can see the combination of the different types of fetal IUGR. Early onset in red, late onset in yellow. You can see on the left we have the early onset, on the right the late onset. If we look to the difference, we can see that degree of placental disease is very severe in early onset IUGR, but is low in late onset. This is the reason why the alteration in placental perfusion is not so evident in the late onset. If we look to the clinical sign in the mother, we can say they are very frequent and early and severe in the early onset, may be mild or absent, speaking about the pregnancy-induced hypertension, for example, in the late onset. Very important, the next line is the fetal tolerance to oxygen deficiency is high in IUGR compared in early onset compared to the late onset. In late onset is low, this tolerance. The meaning is that these fetuses are more fragile. And if we look to the fetal oxygen deficiency, we can see it's very high in the early onset, is low or mild in the late onset. But we have to keep in mind that these fetuses are more fragile. So also a low or mild oxygen deficiency can produce sequelae. If we look at the fetal cardiovascular changes, you can see that are very high in early onset IUGR, and they can be absent or extremely late in the late onset IUGR. But very important is the line related to the fetal sequelae. You can see are very similar with high multisystem morbidity, particularly neurological for both group, early and late onset. The early onset is characterized by the high mortality, the late onset with low mortality. And the problem is the management for the early onset and the diagnosis of the late onset. As I told you at the beginning, another possible scenario is the scenario that I call it the atypical IUGR, which is characterized by maternal healthy condition, normal impedance to flow value in the uteroplacental district, meaning that there is no alteration in placental perfusion, and the atypical fetal hemodynamic pattern that I'm going to show you. It is very important also to make the diagnosis of this group of fetuses because also they are at hypoxic risk. Particularly, atypical hemodynamic patterns refer to a variable and unstable fetal hemodynamic pattern with some episodes or fetal venous district hemodynamic alteration that generally are considered as signs of fetal compromise without abnormalities in the arterial districts. refer to IUGR that is possible even in very early gestational ages, even at the beginning of the second trimester, without alteration in the uteroplacental hemodynamics. Looking at the pathophysiologies of this atypical IUGR, I want to come back to the slides showing the pathophysiology of IUGR. And here I want to underline the umbilical cord anomalies that can produce, with the same pathophysiological aspect, an impaired gas and metabolic change between the mother and the fetus, a reduction in the oxygen supply that can induce some kind of reaction in the fetus. The fetus is trying to face this situation, changing the hemodynamics, reducing the growth rate, and this may produce some alteration in the biophysical profile. So the fetuses try to face this situation in order to avoid the fetal organ system injuries and the fetal death. Here you can see the results of our paper published some years ago related to the observation of IUGR fetuses. As you can see, the vast majority of the cases were related to placental insufficiency, but almost 7% were related to the altered umbilical coiling index. The evaluation of this case that was referred to me for the fetal anomaly scan without amniotic fluid inspired me for the study related to the umbilical hypercoiling and IUGR. I decided to do an amnioinfusion for looking at the fetal anatomy, and I saw, looking at the reason why this fetus was so small, I was looking to the hemodynamics in the fetus and in the placental perfusion, and I saw that it was completely normal waveform profile in the uterine artery, and you can see here normal waveform profile in the umbilical artery, and also in the other district of other arterial district of the fetus. For example, in the aorta, the middle cerebral artery was normal without sign of vasodilation. But look at this, in the same fetus, in the same scanning section, I saw this very strange and very hard to understand waveform profile in the ductus venosus, with a reduction in the forward flow and the appearance of reverse flow during arterial contraction. You can see here also in the inferior vena cava, very strange, because the arterial district was normal. In another segment, checking segment of the umbilical cord, I saw this kind of phenomenon. You can see here the velocity in the umbilical vein is 3 times the peak velocity in the umbilical artery. If we look to the atrioventricular inflow, we can see a pathological waveform profile in the right side of the heart, with an inversion between the E and A waves that is characteristic of the decompensating phase that I showed you in the typical cascade of hemodynamic events in IUGR fetuses. And this is probably due to the fact that the blood going into the umbilical cord is coming from the right side of the heart. So this was the fetus that we take out on on 34 weeks of gestation, you can see the coiling index of this umbilical cord was very high. So in conclusion, we have a different scenario that can be related to the IUGR fetuses. The early onset is characterized by the typical cascade of hemodynamic events, starting from placental functional and structural alterations through the fetal and uterine hemodynamic alteration, leading to intrauterine growth restriction and possibly to fetal injuries, and finally, even to the fetal intrauterine death. We may have late onset IUGR that is characterized essentially by the presence of brain sparing and the alteration in cerebral-placental ratio, and by the absence of the typical progression of the fetal hemodynamic events that we saw for the early onset. This group, even if the hemodynamic events are late and generally less evident in relation to the early onset, may be characterized by possible fetal injuries and finally even fetal intrauterine death due to possible fetal hemodynamic failure that is, as I told you, in generally very late. We may have another possible scenario that I call it the atypical IUGR, which is characterized by atypical hemodynamic pattern with variable and instable fetal hemodynamic alteration characterized by episodes of fetal venous districts hemodynamic alteration, venous districts that generally are considered as sign of fetal compromise, without abnormalities in the arterial district and normal flow in the uterine artery, so normal placental perfusion. Let's to conclude my presentation telling you that when IUGR is suspected and the hemodynamics evaluation show an atypical hemodynamic pattern, the studies of umbilical cord for pathologies like true nodes and anomalous coiling is recommended. When IUGR is suspected, it's very important a multidisciplinary approach, particularly it is important the collaboration with the neonatologist, and is mandatory that the case must be managed in referral center. So, with this take-home message, I'm concluding my presentation. Thanking again for your attention. I'm ready for your question. Thank you.